Well, hello everyone, and welcome to GI Research on the Road. We're here with Dr. Lee live at Digestive Disease Week 2019 in San Diego. Dr. Lee is a gastroenterologist at Michigan Medicine, where he provides dedicated care to patients with functional bowel and motility disorders, such as gastroparesis. And we're actually here to talk to him about gastroparesis today. So many people with gastroparesis are very interested in learning about advances that are being made in the field of diagnosis and care that can improve outcomes for this very devastating disease. So considering our presence here at DDW, the largest gathering of scientists and researchers in the field of digestive health, we wanted to talk to you, Dr. Lee, about some of the new directions that are happening in the diagnosis of gastroparesis. So if I can start out, can you share a little bit about how patients are being diagnosed now?
Sure. Yes, first of all, thank you for having me here. This is a great opportunity to interact with the community. So I think we could start out by just defining what gastroparesis is. And this is a condition where patients have delayed gastric emptying and the absence of mechanical obstruction that leads to characteristic symptoms. And those symptoms are typically upper abdominal pain, nausea and vomiting, early satiety, bloating, and abdominal distension. And so typically patients are diagnosed when they have these characteristic symptoms, and we rule out a mechanical obstruction either through an upper endoscopy or some kind of radiology-based test. And then typically those patients will then go on to get some form of motility testing. And the most common motility test that's ordered now is something called gastric emptying scintigraphy. And this is a radiographic test where patients eat a low-fat egg beater meal that's been radio-labeled with technetium, and then the radiologists measure how much of that test meal is retained over time, and that's typically over 4 hours.
Okay. Well, that's great to know. Thank you. So then in contrast to that, what are some of the new directions that researchers are developing for the diagnosis?
There's a couple of tests that have been approved for diagnosis of gastroparesis. One is a test called gastric emptying breath test, and this is a test where patients eat a standardized test meal that's labeled with carbon-13. And as that test meal empties from the stomach, carbon-13 is rapidly absorbed in the small intestine, it gets metabolized in the liver, and then it's exhaled as carbon dioxide. And we can measure how much carbon dioxide is labeled with that carbon-13 over time to get a measure of gastric emptying. One of the benefits, or some of the benefits of this test, are that this doesn't expose patients to radioactive materials. It's non-invasive, it can be performed in the clinic, and it doesn't involve purchase of expensive equipment that some of these other tests require. The downsides to this test are that it's only measuring solid food emptying, and it hasn't been validated in patients who may have other chronic medical conditions. For example, patients who have chronic liver disease or chronic pulmonary diseases. The second test is something called wireless motility capsule. And this is a test where a subject swallows a capsule that's about the size of a large multivitamin. And this capsule houses sensors that measure pH, pressure, and temperature. And this can give us information on gastric emptying, but also give us information on transit and pressure parameters throughout the entire GI tract. And that's one of the main advantages of this test, is that it can give us this additional diagnostic information that we might not get with tests that only measure gastric emptying. The downsides to this test are primarily the risk of capsule retention, where the capsule gets stuck somewhere in the GI tract and may have to be removed either endoscopically or by surgery. And so if if patients have a history of having a bezoar or having prior gastrointestinal surgery or a history of small bowel obstruction, may not be the best test for those patients.
Okay. Now, I know that a lot of patients do have symptoms but have kind of irregular results for the gastric emptying. For this test, the wireless motility capsule, since it is measuring those other features, is it better at detecting or providing a very confident diagnosis of gastroparesis?
Yeah. I think the evidence is a little mixed in this question. There's been 3 main studies looking at this. The first was the study published by Brad Kuo and colleagues in 2008, where they measured gastric emptying scintigraphy and wireless motility capsule simultaneously in patients with a known history of gastroparesis, as well as healthy controls. And they found that there's good level of agreement between the 2 tests in that study. The second study was a study that was published last year by the Gastroparesis Research Consortium, where they took patients and they did gastric emptying scintigraphy followed by wireless motility capsule. And they found in this study there was lower level of agreement between these 2 tests. But it's important to note there was a significant methodologic difference in the way that the study was performed, and that the study, they did gastric emptying scintigraphy first, followed by wireless motility capsule on a subsequent date. And there could be an interval of up to 6 months between those 2 tests. And we know there is significant variability in our gastric emptying from day to day. And that variation can reach up to 30%. And also, since gastric emptying scintigraphy was performed first, it's possible that some of these patients may have had improvement of their gastric emptying and even normalization for any number of reasons over that time period. And so that may explain some of this discrepancy. The third study is the one that our group published in Clinical Gastroenterology this year. So we took 167 patients with suspected gastroparesis, and we performed simultaneous measurement of gastric emptying scintigraphy and wireless motility capsule. And we found there was good level of agreement between the 2 tests. And specifically, we found that wireless motility capsule identified a higher proportion of patients with delayed gastric emptying compared with gastric emptying scintigraphy. So wireless motility capsule identified about 35% of patients with delayed gastric emptying, whereas gastric emptying scintigraphy identified about 24%. And in addition, we found that about half of the patients had extra gastric transit abnormalities. So transit abnormalities outside of the stomach that wouldn't be identified, again, if we just tested gastric emptying alone. And then one final note about our study that differentiates it from the previous 2 studies is that our study focused on patients with suspicion of gastroparesis, but they hadn't had a formal diagnosis previously. Whereas the prior 2 studies either required or were heavily enriched with patients who have previously been diagnosed. And so we could say that our study probably looks at a more real-world scenario where patients have symptoms of gastroparesis, and we're doing testing to make the diagnosis or confirm why these patients are having symptoms.
That's fantastic. A couple of years ago, we did a broad survey of the community of about 1,400 adults with gastroparesis, and we found that individuals, it took up to an average of 5 years between symptom onset and diagnosis. These new advances in diagnosis, do you foresee that maybe helping kind of shorten that diagnostic odyssey?
I sure hope so. I think one of the issues that we, as specialists who specialize in gastroparesis, I think what we need to provide is education not only to the community but also to our fellow physicians, educating them about this condition and about ways that we can make this diagnosis so that hopefully we can shorten that interval and get patients on the appropriate treatment so that we can get their quality of life and their disease under better control.
Great, thank you. Yeah, absolutely. And then my last question, I know it's still very early in this meeting here at DDW, but I wanted to ask if you've seen anything here at this meeting that is especially meaningful to you, especially interesting in gastroparesis, especially the diagnosis, but even in the treatment.
Yeah, there's been several interesting abstracts that I've reviewed looking at specifically treatments for gastroparesis that I think are very interesting and very promising. One is looking at this medication called Velocitrag, which is a 5-HT4 receptor agonist. So it's working on serotonin receptors in the gut, and we know that serotonin is an important modulator of GI motility. And this is a phase 2b trial, so still fairly early in the process, but they found that Velocitrag improved not only gastric emptying but also symptoms over 12 weeks compared to placebo. Another study was looking at a neurokinin-1 receptor antagonist called tradipitant. And we know that neurokinin-1 receptor antagonists have unique anti-nausea properties. And this study found that tradipitant improved symptoms of nausea and vomiting as well as global gastroparesis symptoms over 4 weeks compared to placebo. And then there's been a lot of interest in this newer technique called GPOEM, which is gastric per oral endoscopic myotomy. And this is a technique where an endoscopist performs a pyloromyotomy, or a cut of the pylorus muscle between the stomach and the small bowel to hopefully improve gastric emptying and also improve symptoms. And this one abstract that's presented here performed a meta-analysis of 8 different studies that was looking at GPOEM in gastroparesis. And they found that 75% of subjects improved with GPOEM over time, particularly if they had symptoms of early satiety, bloating, and nausea and vomiting. However, one caveat with GPOEM is that it's still pretty early with this technique. And I think we really need controlled trials to establish that it is more effective than a sham procedure or placebo. But certainly these results are very promising.
Yeah, it's great to hear that there is so much research interest and there are things in the pipeline that could potentially provide hope to a lot of people who are suffering.
Yeah, absolutely. I think that is something that I try to reinforce with my patients, is that although there are a dearth of effective treatments now, there is plenty of research coming down the pipeline on ways that we can try to improve quality of life and symptoms in gastroparesis.
Great. Well, thank you so much. Thank you to everyone who's watching. This is our first ever inaugural video of GI Research on the Road, so we're very excited and we're so thankful, Dr. Lee, that you were willing to stop by and share a little bit of your special insights on this really interesting topic of new diagnoses, new directions in diagnoses in GP.
My pleasure, and I'm honored to be the inaugural speaker on this program. So thank you very much for inviting me.
Thank you so much.